Oh, can you see this image? Let me just. Okay. Can you see the screen? Okay. Okay, fine. So at Lauren's request, we'll do a session today on myocardial infarction. So this in itself isn't quite so relevant to the inherited conditions, but the ECG patterns are really common ones. Some of the ECG patterns may mimic things that we see in the inherited conditions sphere, and I think it's generally useful stuff to be able to hone your skills in understanding what's going on with these ECGs. Important stuff to know about. Okay, so first of all, let's kick off with a bit of revision from the last session. So last time we did some stuff about rhythms. So we looked at several rhythms, and we compared the normal sinus rhythm, where there's a P, QRS, with every cycle. We compared that to asystole, where there was no ventricular activity at all, no QRS complexes. We compared that to ventricular fibrillation, where there was chaotic ventricular activity, and this being a common mode of death for many of our patients with inherited conditions. We compared that to atrial fibrillation, where it's the atria that are fibrillating rather than the ventricles. So we get this chaotic baseline with no P waves, but we get clearly defined QRS complexes, but these are irregularly irregular, and this undulating baseline. We also looked at ventricular tachycardia in two forms, with a monomorphic form, where it's fast and regular with broad QRS complexes, each of which are similar. That's something common in scar-related cardiomyopathies like ARVC. We looked at polymorphic ventricular tachycardia, which is kind of similar to monomorphic VT, except that every beat changes. It's fast, broad, with a variable QRS shape, often in this sort of sinusoidal pattern called torsade de pointe. That's common in things like long QT syndrome. We then looked at forms of heart block. We looked at second-degree AV block, where some P waves conduct to the ventricles, but some don't. There are more P waves than QRS complexes. And we looked at third-degree AV block, which is similar, except that there's no relationship at all between the P waves and the QRS complexes. They're completely dissociated from each other with a variable timing with every beat. Finally, we looked at premature ventricular contractions, which are really, really common and are something which are really important to know about, because you will see those on ECGs that you will be interpreting, and you need to be able to recognize them and know that these are not the beats that you're going to make your measurements on. And these are broad beats, broad QRS complexes that are distinct from the baseline rhythm. So those are 9 pretty common sorts of rhythms. There are many, many more that we could have talked about, but those are as a baseline, those are 9 common rhythms that we talked about at the last session. So let's go through the homework. So we're going to look at for each ECG, we can describe if there's organized electrical activity, what the rate was, whether the complex is regular or irregular, are they broad or narrow, was atrial activity present, and how is atrial activity related to ventricular activity. And we're going to have a stab at what the rhythm was. So who wants to go first? So you know that everyone's going to get picked, and they're probably going to get harder as they go on. So I would suggest you volunteer quickly. So who wants to go first? What's the rhythm here?
I can try.
Excellent.
So it is regular.
Yeah.
And the QRS complexes are wide.
Yeah.
And the rate is around 150 beats per minute.
Yeah.
I think it is most likely monomorphic VT.
Excellent. Very good. Very good. You're absolutely right. So for bonus marks, what's the axis?
It's northwest. I'm not sure about it. Really looking at the, we see a positive. I'm not really sure about it. Yeah.
Okay, that's fine. So it's negative in AVF. So that means if it was positive in AVF, the axis would be pointing down. I'm sorry, it's slightly positive in AVF, which means it's pointing slightly down. It's negative in lead 1, which means it's pointing over to the left-hand side. So this is a strong right axis deviation that we've got going on here. Okay, you're absolutely right. This is a monomorphic ventricular tachycardia. Well done. Next.
I can try this one. So I think the rhythm is atrial fibrillation because it's irregularly irregular and there aren't P waves and the baseline is kind of wavy.
Excellent, very good. So what's the rate here?
The rate would be because it's like not very regular. I think it's like 75 and then sometimes 60, then sometimes 55-ish.
Okay, sure. Yeah, so but overall, yeah, that's the sort of rate that we've got. Very good. And so in the same patient, why on 1 week might they be pretty slow, but another week they might be very quick?
So this is kind of a guess, but I thought it might have to do with like the signal sometimes not reaching or not passing through the AV node, so there wouldn't be any
very good.
complexes.
Depends on the conduction properties of the AV node, which might be manipulated by things like the drugs that they were on. So very good. Well done. Full marks. Great. What rhythms?
Sorry. For the previous one, my volume got cut off for some reason. What was the pattern? Was that atrial fibrillation or what was that?
Yeah, that's absolutely right. So it's atrial fibrillation. Yeah, Lauren got it absolutely right. We've got atrial fibrillation here with a pretty controlled ventricular response. We talked about how sometimes atrial fibrillation can be fast if you've got quick conduction through the AV node. Sometimes atrial fibrillation can be slow if you've got slow conduction through the AV node. So Lauren was absolutely right. Okay, great. Arminda, you've spoken up. What do you reckon about this one?
I put polymorphic ventricular tachycardia. Okay,
good, excellent. But what other rhythms can you see here? Is it just one rhythm that you can see on this strip?
No, polymorphic ventricular tachycardia more in the middle. I wasn't really sure initially what rhythm to call that. It was almost like, yeah, I'm not really sure about the initial.
Okay, sure. This is tricky, and you absolutely got the main point, which is that there's polymorphic ventricular tachycardia in the middle. So it's a little bit tricky to appreciate in some leads, because in some leads it looks more similar, but in other leads you can clearly see that that you've got this pattern here. If you look, for example, in AVR here, we're clearly starting strongly positive. The amplitude is gradually getting lower and lower until it becomes nearly isometric, and then it's coming back out again. So it's easier to appreciate in some leads than others. So we've definitely got polymorphic VT in the middle. So this first beat that we've got here, I hope you can agree, we've got a P wave, a QRS complex, and a T wave. So we've got a sinus beat here. What's this beat here? The second beat, a broad, abnormally shaped beat that's distinct from the underlying rhythm.
So PVC.
Okay, great. So we've got to start with sinus rhythm. We've got a PVC and another PVC. Then we've got sinus rhythm, and then we've got another PVC that sets off the polymorphic VT, which terminates by itself, and then we've got another sinus beat here with a pretty prolonged PR interval here at this point. Okay, so we've got several rhythms. We've got sinus, we've got PVCs, and we've got polymorphic VT all on one strip here. So this is a tricky one, but you did well there. So what is likely to have caused? What did we say was a common cause for polymorphic VT?
It could be because you're having runs of PVCs. Ventricular tachycardia is can happen, although because of hypoxic states or certain medications.
They could be. That's right. One of the common things that we mentioned. So all right. So to give you a clue on this one, look at the last beat on this strip. Look at the intervals on that strip, and tell me if there are any clues on that last beat as to what might be going on. Is there anything abnormal about this last beat? Look at that. Look at that QT interval. So we've got a long
QT.
Yeah, absolutely. So this is a really long QT that we've got here. So we've got a QT interval that's nearly 600 milliseconds here. Long QT is a really common predisposing factor for polymorphic VT. So whether that's acquired or congenital, long QT is a common cause for Torsad, and you can see that on the last beat here. So very good. This is a tricky one. You did well there. Well done. Okay, next.
I can take this one.
Great.
The rate is roughly 130.
Good.
It's regular.
Yeah.
Narrow QRS. And this is what I figured out is perhaps sinus tachycardia.
Absolutely, totally correct. Very good. All right.
And so the three possible causes would be exercise, sick, or other.
Or other. Oh, you got to have something more than other.
No, I don't know.
Okay, fine. Good. Okay. So yeah, very, very good. So exercise, sickness. There are lots of options as well. So let's pick something like being in pain or being anxious. Being anxious, something that's going to put up your adrenaline for other reasons. Very good. Well done. Okay. Who's next?
I can go next.
Yep.
This was a tough one, but I had different answers and I changed them a few times. But ultimately, I decided to stick with first degree AV block for the rhythm.
Okay. Good. So tell me why you think that.
Let me go to the.
So I'd like you to focus your attention on the rhythm strip here down at the bottom and tell me why you think that's first degree AV block. Focusing attention on the rhythm strip. That's where you can see the P waves most clearly.
The one at the bottom. So the P.
See V1 here. So look at this. This makes it so it's the same beats all the way through, but it just makes it a little clearer on this rhythm strip because the P waves are particularly obvious. So tell me why you think it's first degree AV block.
Well, it was to do with the PR interval.
Okay.
It got longer each time and then it dropped. Well, it was really hard because I couldn't decide if there was the first two beats, QR complexes, and then there was supposed to be a third that was dropped, or is it just
tricky, isn't it? Very good. Okay. So this is you're right. This is a tricky one. So with first degree AV block, what does first degree AV block mean?
The PR is it gets larger each time and then it drops a QRS.
Nearly, but not quite. So anyone else? Can anyone else help Anne out? What's first degree AV block?
That's when a QRS gets missed.
No missed QRSs.
I think it's when there's one big square that takes up the space between like the P to R segment.
That's good. So that's a good start. So the PR interval is long. So that's one key part of it. But what else? But there's still a one-to-one relationship. So there's a long PR interval, but every P wave is followed by a QRS complex. So every beat gets through, but it takes longer to get there. So first degree AV block, there should still be a one-to-one relationship between P waves and QRSs. So if we look at the P waves here, the P waves look a little bit abnormal here because they're really spiky, but that makes them easier to see. P wave, P wave, P wave. Can you see my cursor, by the way, or am I just saying words? Yep. P, 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 P. So we've got more P waves than QRS complexes. Yeah, would you agree? So we've got two P waves before this QRS complex. We've definitely got more P's than QRSs. So this can't be first degree AV block because not every P wave is getting through, right? So could it be second degree AV block? Is there a relationship between the P waves and QRS complexes, but some of them get dropped? Well, if there's a relationship between them, then, so let's see what we've got. If this P wave was conducting to here, then this P wave we're saying might be dropped. What about this P wave? Could this P wave conduct to this QRS complex? It couldn't. That's too short. That P wave can't get through the AV node fast enough to get there. That's an abnormally short PR interval. So that one can't be getting through. What about this one? Are we saying that this one conducts to here and this one and this one? There's no fixed relationship at any time between the P waves and the QRSs. So with a second degree AV block, you would be expecting to see that you might see it as a 2-to-1 pattern, but in that case, you'd be seeing that there'd be a fixed PR interval with half of the beats. Whereas here, the P waves and the QRS complexes are going at completely separate rates. The final thing is that if you've got a second degree AV block, if you're dropping a beat, then you'd be expecting to see a repeating pattern that is irregular with the QRS complexes. You'd expect to see conducted, 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 gap when one drops. Conducted, 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 gap when one drops. But here, the QRS complexes are completely regular. The P waves are completely regular, but they're going at completely separate rates. So there's no relationship between the P waves and the QRS complexes. This is, in fact, third degree, or complete AV block. But this was a tricky one, so good effort, Anne, but not quite right this time, but good effort. Very good. So homework was a little bit harder this time. Well done for making a valiant effort, you guys. Let's move on to the next thing. So myocardial infarction and ischemia. Okay, so let's have a little look about this stuff. So myocardial infarction, this topic really relates quite nicely to the previous one of heart rhythms, because myocardial infarction is a really common cause of abnormal heart rhythms. Depending on what gets damaged, you can cause abnormal ventricular rhythms, you can cause ventricular tachycardia or ventricular fibrillation. If the myocardial infarction damages a region of the heart that contains the AV node, you can cause complete heart block or asystole. If it damages the atria, you can cause atrial fibrillation. So abnormal heart rhythms are a very common complication of a myocardial infarction and are often a cause of death immediately after someone's had an MI. But let's have a look at what it represents. But let's have a look and see what that really means. So the thing that we're really going to be focusing on in this session is the ST segment. So here's our baseline. This is what our standard sinus beat looks like, and it looks fairly normal with normal sorts of intervals. And if we're looking at the ST segment is the bit between the end of the QRS complex, what we call the J point, where the QRS complex meets the ST segment, and the T wave, which is here. So the ST segment is this bit here in between. Now, we want to see, when we're looking at all of this sort of stuff, when we're looking at elevation and depression, we're looking at that this ST segment is going to be displaced from the baseline. How do we even define the baseline? Well, we can define the baseline by drawing a line from an area, from a region that we're going to define as being flat and our baseline. Now that's a little bit arbitrary, but we would normally define that as either being the TP segment, so from the end of the T wave to the next P wave, or sometimes you could use the PR segment. TP is probably better. So if you draw a flat line all the way from here all the way along, that's our baseline. And you can see in this baseline case here, our TP segment lines up with our ST segment, which lines up with our PR segment. And if they're all at the same potential, we'd call it being isoelectric. Iso meaning the same and electric being electric. Okay, so this is an isoelectric ST segment. This is normal. On the other hand, ST segment elevation. Here, if we draw our green line for what the baseline is from the TP segment all the way through, you can see the TP lines up with the PR, lines up with the TP. But here, if we draw a line corresponding to where the ST segment is, if we draw a flat line along there, we can see that these two are quite separated. So here, there's two small squares that are separating the ST segment from our isoelectric baseline. Okay, so this is ST segment elevation, two small squares. This is 2 millimeters or about 0.2 millivolts. Okay, so we can quantify this as well. On the other hand, I have to minimize my screen here in order to do that. There we go. For ST segment depression, if we draw our isoelectric line, here our ST segment is below our isoelectric baseline, isn't it? So TP, PR all lines up, but here our ST segment, if we've got our J point here, between here and the T wave, that's our ST segment, and that is below the line here. So here we've got more than 3 millimeters of ST segment depression. Okay, so that's what it looks like, and the convention is that you'd identify the J point and you'd normally try to measure 60 milliseconds. So that's 1.5 small squares after that. If you're going to try and measure it, you try and measure it at that point there. Or in this case, if our J point was here, 1.5 small squares after that, and you'd be measuring what your ST depression was there. So that's how you'd measure these things. So there are several things that can cause ST segment changes. We'll have a look at we'll mention briefly what the differential diagnoses are. But then the thing that we're going to focus on here is myocardial infarction. So just make sure that everyone's on the same page. A myocardial infarction is caused by a sudden reduction in flow through a coronary artery. So the heart is surrounded by these coronary arteries that wrap around. Normally they're nice and wide and smooth open, but gradually over time they can the walls of these arteries can fill up with fatty cholesterol deposits, and they can cause narrowing of the lumen of the bit that blood flows through the middle. If they crack open, if a blood clot forms there, it can suddenly abruptly narrow, and if it narrows to a great enough extent, then it impairs the flow of blood through there. A region of heart muscle isn't receiving enough blood. It starts complaining, it hurts, and it causes bad things. So if you get ST elevation, then often that means that a major artery has become completely blocked. It's often a total occlusion, and we'd call that an ST elevation myocardial infarction. It looks like this with an elevated ST segment. On the other hand, if you've got a sudden narrowing, but there's still a little bit of blood getting through, we call that that often leads to ECG patterns where you get ST depression, or sometimes acute T wave inversion. So the T waves, instead of being upright, are pointing down instead. So we call that a non-ST elevation myocardial infarction, which is often a partial occlusion rather than a full occlusion. Either way, these are the sorts of patterns that we will typically see, that are commonly seen during a myocardial infarction: ST elevation, or ST depression, or T wave inversion. So here's an example of an ECG where we've got these. So I've highlighted them for you in green. You can see that although it's not present in all regions of the heart, in these that I've marked in green, we've got the ST segments are quite clearly grossly elevated here. And here, wow, they're enormously elevated here, and here, and here, and here. Interestingly though, in some leads, it still looks pretty normal. And in some leads, you've actually got some ST depression instead. So when you have a myocardial infarction, it will generally cause abnormalities in some leads, but not all, depending on which region of the heart is affected. And we'll talk about that a little bit more in a moment. But it means that when you're interpreting an ECG, you can't just look at one lead, you've got to look at all of it, because the abnormalities may not be present in all leads. Here's another example. Here, we've got, rather than ST elevation, here, we've got ST depression going on. Now, in some of the leads, it's a little bit more subtle than some of the leads. I hope I can convince you that if our isoelectric line is about here, we've got a good 2 millimeters of ST depression going on here. Okay, so we can see that we've got ST depression going in all of these leads, and in these leads as well. And there may be even a hint of some ST elevation going on here in AVL. Okay, sorry, AVR. So we've got pretty widespread ST depression and ST elevation in AVR. Here's an example of T wave inversion. So in some leads, our T waves are upright, as we'd expect, like here in lead 3, in lead 2 over here. But in these leads, from V2 all the way down to V6, our T waves are pointing down when they should be pointing up. So this is T wave inversion. So those are 3 real world examples of the sorts of patterns that you might see during the early phase of a myocardial infarction. But I say the early phase because these ECG changes change over time. That's our baseline at T equals 0. At 1 hour, following an ST elevation MI, which we remember is normally caused by a complete occlusion of a main coronary artery, we get our ST elevation pattern like this. All the things I want you to notice are that the R wave is still tall, and there's still very little in the way of a Q wave here. Between 4 and 12 hours, things evolve. So as the ischemia progresses, that region of the heart starts to die, or the cells start to die. Between 4 and 12 hours, we still have ST elevation, but now we have development of a pathological Q wave. So normally, you may see a tiny little Q wave in leads, in most leads, and that can be a normal thing if it's very small. If we want to be specific, it's less than 25% the height of the subsequent R wave. But here we've got a great big Q wave, and that's definitely pathological. That's abnormal. So we've got a large Q wave that's almost as big as the following R wave. So between 4 and 12 hours, we start to develop Q waves but we still have ST segment elevation. And you can see that the T waves are starting to go down here as well. 2 to 3 days after a myocardial infarction, the ST segments will generally, not always, but will generally start coming back down again. The Q waves will remain. You can see that the R wave is much smaller than it was at baseline. And we've still got this big, deep T wave inversion that has in fact evolved even further. The T wave inversion has progressed more between 12 and 48 to 72 hours. Finally, weeks to months later, things will end up where you remain with a Q wave, but the ST segments will most of the time normalize, and the T waves will come back up again as well. So this is the pattern of evolution that tends to go on. So the things that I want you to pay attention to are that these sorts of patterns are the things that you might see acutely. You're unlikely to notice those on any ECGs that you're asked to interpret, but you might see patterns like this, where you have an abnormal deep Q wave present in some leads. Myocardial infarction isn't the only thing that can cause abnormal deep Q waves, but they are definitely abnormal and they're something to pay attention to. Okay? And one of the things that can cause that is a previous myocardial infarction. So, for example, in this ECG, rather than being in the acute phase of a myocardial infarction, this is someone who had an MI quite some time ago. And you can see that in these leads, in leads 2 and 3 and AVF, we start out our QRS complexes with deep Q waves that in this case are even larger than the subsequent R wave. There's still a little bit of ST elevation here that's present in these leads, because most of the time the ST segments normalize after a myocardial infarction, but in some cases the wall can be so damaged and aneurysmal, so bulging out a bit like a balloon, that you can get persistent ST elevation even years and years after an event that's there forever afterwards. But these are clear deep Q waves that are very abnormal. So I said that that these may affect some regions, that the ECG abnormalities may be present in some leads, but not others. But to get an understanding of why that might be the case, we need to have a little bit of understanding about how the coronary arteries work. I'm not expecting you to remember all of this, but it's useful to know that there are 3 main coronary arteries. The big one runs right down the middle between the left and the right ventricle. That's called the left anterior descending coronary artery, that big red one that runs down the middle here. That's big and important, and it supplies the front of the heart. We've got a right coronary artery that wraps around the right-hand side and then comes back down round the back, supplying the posterior aspect and the inferior aspect of the heart and the right ventricle. And then we have a circumflex artery that wraps around the side and covers the side of the heart here. Now, all of these have lots of little sub-branches and the rest of it, but it's a useful thing to know that there are 3 main coronary arteries, and any of these can get blocked, but each of these supplies a different region of the heart. If we're going to look at the territories, this is where my art falls down. I can copy images off Tinterweb, fine. But my art gets a bit more challenging. I have to draw it myself. But I want you to imagine that this is a cross section of the heart that I put superimposed there, looking like this. So if you can imagine, you're looking through the heart as a cross section with your left ventricle here as a big donut shape, and the right ventricle as a sort of a crescent moon stuck on the side of it. Left ventricle and right ventricle. The idea is that we can talk about the heart in different areas of the heart in different ways. We can talk about the bit at the front being the anterior, the bit going out to the side as being lateral, and the bit at the bottom being inferior. So these are terms that you may see bandied around when it comes to the heart, but it's useful to be able to understand what those mean when we're referring to different regions of the heart. And different regions of the ECG correlate to different coronary territories. This is a bit difficult to wrap your head around, so it's just sort of patterns that you learn to recognize over time. But it's hard to take it in at a first glance. But in general, the inferior ones are the ones that are pretty easy to wrap your head around. So if we remember which regions of the heart each lead is pointing out, you remember that 2 and 3 and AVF are all pointing downwards. So any changes in the ECG that we see that are maximal in these leads are probably influencing the inferior region of the heart. On the other hand, leads that are pointing out to the side include lead 1, which points straight out at 0 degrees on our axis, and AVL. And also in our chest leads, V5 and V6 are all pointing to the lateral aspect, the side of the heart. On the other hand, ECG leads pointing at the front. If our chest leads are through V1 to V4 are all anterior leads. So these are the sorts of patterns that abnormalities of the heart caused by a blockage of a coronary artery might affect. So let's look at some more ECGs then. So here we've got some abnormalities. Here, once again, we've got gross ST elevation, but which leads are these present in? So we've got ST elevation, we've got a little bit in V1, a lot more in V2, an awful lot in V3, V4, and V5. So remember that V1 to V4 were anterior, and V5, V6, 1, and AVL were lateral. So this is an anterolateral ST elevation myocardial infarction. And you can see that here we've got the ST elevation and we've got the Q waves that are already forming. So remember from that pattern of the temporal evolution of ECG changes, that this isn't something that's happened in the last hour. This is something that's been going on for a few hours already. Okay, this is an anterolateral myocardial infarction. On the other hand, this one's different. So we don't have the ST elevation present in these anterior leads anymore. Instead, the ST elevation is maximal here in leads 2 and 3 and AVF. We also have some again in V5 and V6. So this is an inferolateral myocardial infarction because it's affecting the inferior leads. 2, 3, and AVF point to the inferior aspect. V5, V6, 1, AVL point laterally. So it's predominantly an inferior with a slight lateral component to it. We have this ST depression present in V2. So we often get in the territories that don't have the ST elevation, we often have what are called reciprocal changes, which means ST depression in leads that are opposite those which have the ST elevation. So it's an infralateral acute myocardial infarction. And here, this looks like it's in the early stages. We've got the ST elevation, but we haven't got development of Q waves yet, and we don't have any T wave inversion. On the other hand, this is just affecting the lateral side. So here we've got ST depression in 1, 2, in this case, V4, V5, V6. Not so much an AVL this time. And this is ST depression rather than ST elevation. So this is a non-ST elevation myocardial infarction. And it's probably affecting the lateral aspect of the heart. I say probably, because if you're localizing things on the ECG, if you're localizing ST elevation, then that's a pretty robust way of localizing things. Things like ST depression and T wave inversion, the relationship is much less robust. So it might genuinely be the lateral aspect of the heart, but it might be another region of the heart as well. It's a little bit less specific, localizing based on ST depression or T wave inversion. So it is important to bear in mind that there are other causes for ST segment changes. Don't expect you to remember all of these things, but just be aware that not every ST elevation is a myocardial infarction. Things that are particularly relevant to us in the inherited condition sphere would be things like early repolarization and Brugada syndrome can cause ST elevation. There are other things that we're going to cover in later sessions, deficits of conduction like a bundle branch block or having a pacemaker, they can cause ST elevation or ST depression. Abnormalities in electrolytes and the rest of it. And there are some clues that you can use to judge what's going on. You can look at whether the ST elevation in early repolarization is more concave. So if you drew a line from the J point up to the apex, it kind of scoops down like this. Whereas in a myocardial infarction, it's more likely to be non-concave or convex even. So sort of going in the opposite, sort of wrapping around that line that connects the two, more like this. You don't need to remember all these things, but just be aware that there are causes for ST segment changes other than just myocardial infarction. You've got to take these things in context. Okay, so here we've got, we're just gonna look through a few examples here then to confirm what we've gone through. So here, once again, we've got an ECG showing a sinus rhythm. It's going a little bit quickly. We've got ST elevation. The ST elevation is mainly present in leads 2 and 3 and AVF, also in V4, V5 and V6, lots of ST elevation. We have some reciprocal ST depression in V1 and V2 and AVL. And if we're going to judge the timing, we're going to say that we've got lots of ST elevation. We've only got very small Q waves at the moment, so this looks like it's probably fairly early on in the process. So this looks like an acute inferolateral ST elevation MI during the early stage of the process. The patient's probably got a sinus tachycardia because they're feeling pretty sick. This is a big MI, and they're in pain, and that's probably what's giving them a sinus tachycardia. This ECG hasn't projected quite so well, but here the main abnormalities are that once again we've got a sinus rhythm. This time we're going at a normal rate with 1, 2, 3, 4 big squares between QRS complexes, so our ventricular rate is about 75 per minute-ish. This time we've got T wave inversion in V1, V2, V3, V4, V5, and we're biphasic in V6. We've also got T wave inversion in lead 1 and AVL. So in the right sort of context, this can fit with a myocardial infarction, a non-ST elevation myocardial infarction. This sort of pattern is typical of again, an anterolateral non-ST elevation myocardial infarction. Okay. What about here? So here, we can't see any ST elevation. If we start from the beginning, we've got a sinus rhythm with P, QRS, T. Our ventricular rate this time, once again, if we look at if we start with a lead that's pretty close to a big square, we've got 1, 2, 3, 3.5 big squares between each QRS complex. So our rate's going to be somewhere between 75 if it was 4 squares and 100 if it was 3 squares. So let's call it around 80, 85 in a sinus rhythm, a normal rate. Don't have any ST elevation. What about our T waves? No, our T waves are all pointing up. There may be a little bit of ST elevation here, but it doesn't look particularly pathological because it's got that concave appearance upwards, hasn't it here? It's got that scooped pattern, which is less commonly associated with MI, but it could be. But we have got big Q waves present in V1, V2, V3, V4. So this is most likely to be someone who's had a large myocardial infarction in the past. You can tell it's a big one because not only have they got very large Q waves, they've got no R waves at all. Their R waves have been completely replaced by Q waves. And they've got this scooped appearance, which is the sort of thing that you might find after a large myocardial infarction, where they have an aneurysmal segment in that place left behind. What about here? So here, this time, the ST elevation now doesn't have that scooped concave appearance. It's got that convex appearance here, hasn't it? We've also got ST depression occurring in other leads as well. So this is much more suggestive of something which is more acute and ongoing. So here we've got a combination of Q waves, ST elevation with an abnormal appearance, but also reciprocal ST depression in other leads. So this is suggestive, again, of an anterolateral myocardial infarction, but one that is ongoing, but has been ongoing for at least 4 hours, probably more than that, maybe 6, 8, 12, because those R waves have gone. We've got deep Q waves that are formed. We've still got ST elevation, ST depression, and now we're starting to develop some T wave inversion. This looks like someone who's been sitting on their myocardial infarction for a while and trying to tough it out rather than seek medical attention. This is someone who's less likely to do well in the long term. And that's about it. that's what we've got for today. So if I stop sharing there, any questions about what we've talked about?
Well, I have a question. It's actually quite general. Why are the different leads different? How are they different? Why are the different leads?
So do you? I can't remember, Claude. Were you there? I've got a feeling you missed the first session.
Yes, I did.
So we talked about it in the first. We talked about it in the first.
I understand that it's coming from a different place. I guess it's measuring a different part of the heart, and I can understand that would give a different curve. But what about when QRS complex is totally absent in one of the leads and it's present in other leads?
Okay,
all right. Why is that happening?
So that's a brilliant question. So to get that, we've got to get back to the fundamental of how the ECG is formed. So the ECG, the leads that we're seeing on the ECG, we refer to them as leads on a strip. That doesn't actually mean the wires that are attached to the patient. So although we've got 12 leads, which we see on our strip, we actually have 10 stickers and wires connected to our box.
Yes.
Each of the signals that we're getting is we are measuring the electrical difference between two or more of those ECG stickers that we've stuck on the patient's chest.
Mm-hmm. Yes.
If we get a positive deflection on the ECG, that means that we've got electricity moving towards the positive electrode that we're measuring on the chest. Electricity is moving towards it. On the other hand, if we've got a negative deflection, it means that we've got electricity that's moving on average away from that electrode. So positive towards, negative away. But we've got a 3D structure that's inside there. Things aren't just moving towards and away. Things can be moving, but not either towards or away. They could be moving perpendicular to the difference between those leads, if that makes sense. So if you imagine you had one, in a fictitious example, if you had one ECG electrode at the top, one ECG electrode at the bottom, electricity moving up would give a positive deflection. Electricity moving down would give a negative deflection. Electricity moving from side to side would give neither a positive nor a negative deflection. On the other hand, if you had a second set of ECG electrodes, one on the left and one on the right, moving side to side, moving right would give a positive, moving left would give a negative, but moving top to bottom would give a flat, would just give a flat line.
Okay.
From the perspective of different ECG leads, in one ECG lead, if it's moving parallel to the direction of the difference between those electrodes, you're going to get a large signal, either positive or negative. But if it's moving perpendicular to these electrodes, it's going to be almost flat.
Oh, yes, I see.
Is that kind of, for example, for the first homework question, the monomorphic ventricular tachycardia, kind of what was happening in lead 2, where the rest show those broad QRSs, whereas lead 2 is just a squiggly line, basically?
Let's have a look. Let's go back to the share screen. Are you going to work for me? Right, this one. So yeah, you're absolutely right, Amanda. Right. So in this case, in V1, V2, V3, we've got large positive and negative deflections. In lead 2, it's pretty much flat. And you're absolutely right. It's because from the perspective of lead 2, the waves of electricity are moving almost perpendicular from the perspective of where lead 2 is looking. It's not quite the case because things aren't moving in an absolutely straight line. They're bending around in a complex 3D structure, but in compared to the rest of it, it's almost flat compared to very large QRS complexes that we can see in other leads, because it's not, because it's the orientation of the average movement of the wave of depolarization is much more parallel to these leads rather than perpendicular. So yeah, you got it right.
Is there a sequence in terms of chronology or time of these leads? Is one happening prior to the other?
No, so
They're all happening at the same time. They're all reading at the same time.
So for the way that it's set up for most ECGs is you've got so time is continuing from time continuously. So all of these leads are lined up. So the rhythm strip got down here at the bottom is one continuous strip, and all of this is lining up. So you're right that V4 is happening after lead 1.
Okay, yes, okay.
You've got the rhythm strip at the bottom as a timing reference to, so this is one complete, whatever, 15-second period. Yes. But yeah, does that make sense?
Yes, yes. And I was wondering, are there certain leads that we should be looking at more than others?
No, you've got to look at all of them. So there are certain leads that you are more likely to pick up certain information in, but if you want to have a thorough interpretation of an ECG, you need to look at everything. Some things it will be easier to measure in some leads than others. So, for example, if you're trying to identify P waves, as we've just talked about, you're going to see the biggest deflections if you're looking in leads that are in which which are parallel to the average wave of depolarization in that structure. So in general, in a sinus rhythm, the atria are depolarizing from the top to the bottom. And so leads that you will typically see larger P waves would be things like in lead 2. They're also depolarizing from the back to the front, and so you'll often see them quite well in V1 as well. So you can see P waves pretty clearly here in lead 2. You can see them pretty clearly in V1, but then on the other hand, you can see them, but they're harder to pick out in things like lead V6 or lead V3. So there are some leads where it's going to be easier to spot things than others, but that's not always going to be the case. Equally, when you're doing measurements like things like the QT interval, which we're going to talk about in another session, there are some leads where it's easier to identify where the T wave starts and finishes, where the T waves are more prominent, whereas in some cases the T waves are very flat. So it would be very hard to measure the QT in lead V2 here, for example, because it's very, very flat and very hard to work out where the T wave is going to end. So it'd be much easier to measure it, for example, in lead 2 here, because you've got a much more defined end to the T wave here. So you need to look at the whole lot, but you may be focusing your attention for certain aspects of the information you're trying to pull out in certain leads.
Has there been any work on merging leads?
Yes, absolutely. So that's what I know the project that we've been doing together, looking at the signal averaged ECG, is a merge of those leads. So it does things in a slightly different way. It merges leads, not only merging different leads simultaneously, it's also merging leads temporally. It's averaging beats over time to give a composite signal. So that's exactly what the signal averaged ECG is.
Okay. Well, thank you very much. That answers a lot of my questions.
Okay, good stuff.
That's
cool. Did anyone have anything else?
I actually sort of had one more question about the homework, like the third one, if you don't mind pulling it back up.
Let's go back up to that one. Yeah.
Yeah.
So the third one, which one? So
the one with PVC.
1, 2, 3. This one.
Yeah. So you said like the last kind of segment, it looks like long QT syndrome.
Yep.
So I was just a bit confused when I was like initially doing the homework, because I wasn't able to see like P waves until I looked at like the lead V1 to V, I guess, 6. And I wasn't sure if those were P waves or if they were like T waves that were kind of like notched, I guess.
Yeah. Are you talking about this little bit here?
Like the one after it.
Here.
Yeah.
Yeah, it's kind of hard to make out, isn't it? I think this is the P wave here. So there. So if we look here, so we've got that's the P wave that we've got going on here.
Right.
And this is an abnormal notched T wave that we've got going on here. With a very long, very prolonged T wave here.
Okay.
But it is tricky. It's tricky to work out from here. So this isn't the sort of strip that you would. This is an interesting ECG that I put in to challenge you guys a little bit. But this isn't the sort of ECG that you would be using for assessing someone's QT interval if you wanted to make exact measurements, because with all these things, if you want to measure the QT interval precisely, then you want to be having a nice stable ventricular rate between all of these things so that you can appropriately adjust for it and all the rest of it. But as a rough by eye thing, by eye, this is grossly abnormal. But this isn't the sort of trace that you'd be using to accurately measure to accurately measure it. Does that make sense?
Yeah, totally. Thanks a bunch.
Good stuff. Okay. So I think we're going to draw it to a close there. We'll have the next session in a couple of weeks' time. I will send you through some homework from this session. Please, if there are particular topics that you want covering, so Lauren, thank you very much for the suggestion about myocardial infarction. So we've done this one. If other people have something that they particularly like covering, then please drop me a line. Otherwise, I'll come up with whatever I feel like. Okay.
Hey, Charlie, just a quick question. Whenever they ask if there's organized electrical activity, that's if it's actually going atria to ventricle without any deviation. Would that be correct, or is it that too broad?
So when we talk about organized electrical activity, really that's looking to see whether essentially you're trying to pull apart ventricular fibrillation and asystole from anything else. So if you've got a flat line, there's no organized electrical activity. There's no electrical activity at all. If you've got VF, it's completely chaotic and disorganized. It's not organized at all. So that's really what you're trying to pull out.
Okay.
Okay. Good stuff. Right. I'll send you the next slide. Thanks. Good to see you guys. See you next time.
Thank you.
Thank you.
Thank you.